This is Dermatology Weekly, the official podcast of MD Edge Dermatology. Welcome to episode 94 of Dermatology Weekly. Coming up in the peer-to-peer portion of the show, Dr. Seemal Desai hosts a conversation about vitiligo. But first, this week in dermatology news. And in dermatology news, we begin with a review of two dermatologic emergencies in children. The review comes from Dr. George Hightower of Rady Children's Hospital at the University of California in San Diego. Eczema herpeticum, staphylococcal scalded skin syndrome, can be emergencies in children and require immediate care, according to Dr. Hightower, who spoke at the Medscape Live Women's Pediatric Dermatology Seminar. Eczema herpeticum is a condition where herpes simplex virus 1 or 2 is superimposed over pre-existing eczema. The infection may be primary and sustained from a close contact or result in some of our older patients from reactive or spread through auto-inoculation. Dr. Hightower said that signs include acute worsening of atopic dermatitis with new onset vesicles, pustules, and punched-out hemorrhagic crusted erosions. The presentation ranges from mild to transient to life-threatening. Potential complications include meningitis, encephalitis, hepatitis, and chronic conjunctivitis. That's why immediate ophthalmological evaluation is needed when there's involvement of the face near the eye. Regarding management, Dr. Hightower said where he has concern for HSV patients is he gets a PCR as well as a bacterial culture. But even before the results are available, empiric treatment with acyclovir can be appropriate. During his presentation, Dr. Hightower also highlighted staphylococcal scalded skin syndrome. Affected patients commonly have concurrent skin pain, fever, irritability, malaise, and poor feeding. Examination may reveal widespread arrhythmia and anticoagulation at folds, peeling at hands, and large sheets of superficial peeling scale with diffuse erythema. Widespread skin involvement results not from the presence of staph throughout the skin, but the exotoxin that produces that becomes systemic. Clinical diagnosis is supported by presence of S. aureus in bacterial culture, but the presence of staph is not necessary to make the diagnosis. When in doubt, histopathology is helpful, but again, it's not necessary to make the diagnosis. Dr. Hightower said that in cases he managed with a first or second generation cephalosporin. While Dr. Hightower doesn't use clindamycin in these patients, he said it's an option that some dermatologists consider because of its anti-staphylococcal activity. He noted that historically, people thought it may decrease exotoxin production. The big concern if you're going to use clindamycin is that there are high rates of community resistance. Dr. Hightower concluded by saying that you want to be careful, that you know that you're resistant patterns whatever you use. Follow up on the culture to make sure that you have adequate coverage for the bug that the kiddo in front of you has. And we move now to pre-adolescent acne. Also speaking at the Medscape Live Women's and Pediatric Dermatology Seminar, Dr. Andrea Zenglein told her colleagues to treat acne from near birth to adulthood with a growing level of aggressiveness as a child ages. No treatments may be necessary for acne in the first few months of life, but the condition can leave scars in children as young as 3 months old. Dr. Zenglein is a professor of dermatology and pederm at Penn State, which is in Hershey, Pennsylvania. Neonatal acne occurs in more than 20% of newborns aged 2 weeks to 3 months. Dr. Zenglein noted that typically this doesn't need to be treated, but if you do, you could use a topical antifungal twice a day, but in most babies, this will just improve over time and resolve without any scarring or sequelae. She said that the infantile acne begins at about 3 to 6 months old and lasts up to 2 years of age. She said that you will see comedones and infantile acne, so it's a true form of acne due to increased adrenal production of the androgens. For infantile acne, she recommends performing a full skin exam to rule out hyperandrogenic disorders such as Cushing syndrome, congenital adrenal hyperplasia, premature andronarchy, and gonadal adrenal tumor and precocious puberty. Treatments are similar to those in teenagers, but for younger patients, you need to make sure to use baby-friendly formulations with lower concentrations of active ingredients. She also said that you need to make sure to avoid tetracyclines and B, benzoyl peroxide washes, as benzoyl peroxide can be used in leave-on formulations at lower strengths. She said that erythromycin can be appropriate at about 30 to 50 milligrams per kilogram per day in 2 or 3 doses, but there are possible gastro side effects. Azithromycin at 5 milligrams per kilogram per day is another option. Dr. Zanglein went on to say that going to isotretinoin is rarely needed, and that she thinks that in all her years in practice, she's only ever treated one baby with isotretinoin in infantile acne. Mid-childhood and pre-adolescent acne conditions occur in children starting at ages 1 up to 10 years. In this population, she also recommends ruling out hyperandrogenism by looking for secondary sexual characteristics with full-body skin exams. She said that the workup can be broad and includes looking at adrenal androgens and total and free testosterone, as well as looking at growth charts and bone age. Typically, you'll refer these kids to pediatric endocrinology. Milder cases of acne in this age group can be treated with salicylic acid wipes, and these things are kind of a rite of passage. But if they have any more severe acne, you're going to want to treat it more or less like you do with adolescent acne. And that's it for this week in dermatology news. Coming up after this, Peer-to-Peer.
Zurigo Health, formerly known as Clarify Medical, has rebranded to better align with our new corporate platform strategy. Zurigo's goal is to bring home phototherapy to the forefront for mild to moderate psoriasis patients while providing optimal outcomes for patients, cost savings for payers, and ease of prescribing for physicians. This new model means we will be working with payers directly to create a comprehensive program for their psoriasis patients that includes conveniently administered, targeted, narrow-band UVB phototherapy at home. The smartphone-connected Zurigo Solution software controls proper dosing while remotely monitoring patient adherence, compliance, and clinical progress through our Zurigo Care partners.
Welcome back to Dermatology Weekly. It's now time for the peer-to-peer portion of our show.
Hello and welcome. I'm Dr. Samal R. Desai. I'm a board-certified dermatologist in private practice in Dallas, Texas, the founder of Innovative Dermatology, and I'm a clinical assistant professor in the Department of Dermatology at the University of Texas Southwestern Medical Center. And it's my pleasure today to be your guest host of Dermatology Weekly. Today, I have the pleasure of talking with my amazing friend and colleague, world-renowned dermatologist, Dr. Pearl Grimes, who's the founder and medical director of the Vitiligo and Pigmentation Institute of Southern California. Dr. Grimes is a vitiligo tour de force. I've learned so much from her in my years of working together, and she's a true friend and colleague. Pearl, thank you so much for joining us.
Samal, it is truly my honor and pleasure to join you and be a part of this session.
I think our listeners, Pearl, are in for a real treat. At least that's my bias going into this. I always enjoy talking with you, and we always come up with such great ideas and projects when we collaborate. But let's dive right in, and we're going to focus our discussion today on vitiligo. But we want to focus, I think, a little bit both as vitiligo expert clinicians. Pearl, you and I share patients even between Dallas and Los Angeles. We also have seen patients from around the world. Let's start off by getting your insights on the need and what do you see as, what do we need to do to better classify our vitiligo's patients' disease status? So active, unstable disease, chronic disease, refractory. How do we need to classify disease in our patients with vitiligo?
Happy to answer that question, Samal, but I'm also going to preface it by saying for our listeners, I think they're going to get the thoughts and the opinions of two individuals who are truly passionate about vitiligo. And we've been in the trenches with vitiligo patients for many, many years, and I remain there because it is my passion. And every day when I see a patient who is doing well, it just brings me renewed joy as to why I continue to do what I do on a daily basis. Now, to answer your question, how do we classify vitiligo? I think that there are some aspects of classification that are really key from a therapeutic perspective as well as a prognostic perspective. The things that I look at on a day-to-day basis when I work up any new patient includes what type of vitiligo do you have? Is it non-segmental or is it segmental? Is the patient stable or are they progressive?
Right.
And then I look at the severity of disease. All of these parameters clearly impact how I go into my therapeutic bucket, my armamentarium, to choose the appropriate treatment. And it also impacts what I know I need to do for that patient long term from a prognostic perspective.
So I knew this was going to be fun because you're reading my questions in my mind. We're going to jump to therapeutic armamentarium in just a minute, but I like what you said because I completely echo your passion and commitment to these patients. And I think that hopefully our listeners, even if they're not experts in vitiligo and pigmentation, they will at least now be able to think a little bit outside the box after hearing some of our tips. One thing I wanted to talk to you about is when you have that active, unstable patient, remember we've talked about in consensus meetings together where you and I have been at the table, if you have a patient who has expanding depigmentation, more than 1% of their own body surface area in a month, or 1 to 2% of their body surface area in a month. You know, many of our colleagues in India and in Asia count that to be a way to quantify unstable vitiligo. Do you like that kind of concept to help your patient really tell you more tangibly how many more white patches are you seeing? Do they fill up the whole palm of your hand?
Well, you certainly could be that rigid. I tend to be a little bit more lax, but I query that patient regarding any new lesions in the last month, 3 months, or the last 6 months. I also do ask them, what about the extent of that progression? Then, if I'm comfortable regarding whether or not it's minor progression, some patients are traumatized by a punctate change, and I have to get them to refocus and not become overwhelmed by minor changes. But certainly, if we feel that that patient is unstable and they're having a major progression, then I do not hesitate to include modalities for stabilization. So I think this is a great segue into what therapies we use for stabilization. In my practice, the key therapies are systemic corticosteroids. I also think that supplements help with stabilization, but I'll address corticosteroid stabilization first. I think the two key methods that we use are oral mini pulse dosing for stabilization, giving dexamethasone 2 to 4 milligrams on 2 consecutive days per week. I also like intramuscular Kenalog. Many of my colleagues don't, but I find that it works for me because patients don't have to take a pill every day. I give that injection once every 6 weeks, and very often patients will stabilize with one injection.
I agree,
So
Pearl, and
it's
I learned that from you. The intramuscular triamcinolone steroid, I learned from you back in the day. And when I'm on podium lecturing about vitiligo, I still credit you with that because even in the era of oral mini pulse, like you said, IM Kenalog or IM triamcinolone still has a role.
absolutely. The only issues are, and I have my patients, I make them aware of this for whenever we're doing the injections. You can get some fat loss at the injection site. It's not permanent. It always resolves. That occurs in maybe 2 or 3% of patients. The other complication in women, they can have some menorrhagia. And again, it is the minority of patients, and we make them aware of this prior to the injection. And I give patients an option. I can give you an injection, or we can do oral mini pulse dosing. And so I don't dictate. We make the decision together. And very often, many of my patients will say, I want that injection.
I
And it
like that.
works.
And I agree. I agree with you that stabilization is key. And if we don't stabilize our unstable vitiligo patients, we're doing them a disservice. I've heard you say that. I've said that on podium. And whatever I do, if I don't even have a colleague who can refer a patient to me, what I tell them is if you have someone who's unstable, at least stabilize those patients and give their skin a chance to repigment, because we do have data that shows the longer the skin is depigmented, the harder it is to repigment. Pearl, talk to me a little bit about also your topical regimen. What do you like to use topically between steroids, calcineurin inhibitors, off-label use of the Janus kinase topicals? If you have a new patient who comes in, you're stabilizing them with mini pulse, you're starting phototherapy, how do you do your topicals?
Before I answer that question, Samal, I'd just like to make one other comment
Please.
regarding other therapies for stabilization that are in the literature. There's minocycline, methotrexate has been used. And I think it's important for our audience to also know that narrowband UVB phototherapy can also be effective in helping to stabilize vitiligo. So as far as my favorite topical modalities for vitiligo, certainly we've used topical corticosteroids and the calcineurin inhibitors for many, many years, and those modalities remain my workhorse. We did the work on the calcineurin inhibitors, specifically tacrolimus. I think we reported that data around 2001. And I still have patients that from that original study that I follow. So you can use them as monotherapy very often to optimize my outcomes. In the first few months of therapy with patients, I will combine them. I may use the steroid in the morning, a calcineurin inhibitor at night. Once after I get through the first couple of months, then given the fact that we don't experience any atrophy or thinning of the skin with the calcineurin inhibitors, very often I will keep those patients on a calcineurin inhibitor for an extended period.
I agree with you. So let's recap what you said, because I think our listeners need to hear what you said. Oral mini pulse therapy and or intramuscular steroids can help stabilize. Phototherapy is a great stabilizing agent. I agree. If I have someone who's unstable, I'm going to try to do both systemic and phototherapy, also topicals, and also the antioxidants. And we're going to come back to that in just a minute. Let me just probe a little bit and be controversial. I know what you're going to say, but I love to poke at this question. Would you hesitate to use a class 1 steroid like clobetasol on the face for a short period of time?
I'm happy to answer that question. In general, my topical corticosteroid workhorses for the face are the mid-potency steroids. I like mometasone.
Agree.
I will, yeah, I tend, the low potency steroids don't work.
Right. And that's an important point that Dr. Grimes just made. That's critical that our listeners know that, is that if you're going to use topical steroids, we are the artists. As board certified dermatologists, we are the ones who can tailor the regimen. You can't be scared of topical steroids either. And doing a 2.5% hydrocortisone on the face is not going to accomplish anything. So that's kind of why I was being a little kitschy in asking you that question. So I'm glad you said that.
Yeah, so let's peel the onion a little bit more though. My standard corticosteroid for the face is a mid-potency steroid. I like mometasone, for instance. The lower potency steroids, hydrocortisone, for instance, they don't work as well. So I would recommend that you use a mid-potency steroid. You simply have to monitor your patients. You give them a limited quantity. Now, to be even more specific, Samal, and answer your question, have I used clobetasol on the face? You know that I have.
Absolutely.
Again, I tend to use it in a patient who is more recalcitrant. I monitor that patient very closely. I get them on and off as quickly as I can. If I'm going to use clobetasol on the face, there's a great likelihood that patient is going to interact with me in a month, so that I'm in total control of what happens.
And guess what? I know you and I never write a prescription with topical steroids with multiple refills. We never do that. And I know you and I are both very strict on that because we want to dose and monitor how much we give. Okay, let's quickly go back to oral mini pulse before we move on to the JAK inhibitors. So oral mini pulse, on average, I'll tell you what I do. I prescribe 8 weeks worth when I'm doing it. So Saturday, Sunday, Saturday, Sunday, Saturday, Sunday, so on and so forth for about 8 weeks, and see the patient back in the 4 to 6 week mark, but give them a few extra tablets to continue. What is the max longest you've ever done oral mini pulse? Have you done it a year? Have you done it 6 months? What's the max you've done it?
My max for oral mini pulse is usually 3 months. And what I will do is I will give them a course for 6 weeks. I will have them follow up with me in 6 weeks, and then I will adjudicate the need as regarding whether or not I need to do it for another 6 weeks.
Perfect. So that's a good soundbite for our listeners with some practical data. Let's talk in the next few minutes about the JAK inhibitors. You and I have talked extensively about 2% tofacitinib cream, and you've published, you've done the studies on ruxolitinib cream. I'm in that trial as well for the 1.5% cream. I use these topicals off-label. I know that you and I like ruxolitinib topically compared to tofacitinib topically. Talk to me a little bit about that.
You know, in the early days when we were beginning to compound extemporaneously tofacitinib as well as ruxolitinib, I used both. And as I continue to move forward using the topical JAK inhibitors, I just came to realize that I was getting a better response with topical ruxolitinib versus tofacitinib. So when I compound now, it's almost exclusively ruxolitinib. And, you know, given what we do in the clinical situation and what we've gleaned from the ruxolitinib trials, we have excellent data now, which suggests that the 1.5% ruxolitinib has significant efficacy and safety, and we get very nice responses, in particular on the facial areas.
Completely agree with you. Let's switch gears just for the last few minutes and talk about psychological impact of vitiligo and how, I think you and I both know, having experienced this for years with patients, me with family members, you knowing personal friends and family members, how big is the psychosocial impact of vitiligo, and what can our listeners do to help patients through that?
I think that vitiligo is no doubt one of the most psychologically traumatizing and devastating disorders that we see in dermatology. If you really take a deep dive into the emotional impact, we find that patients experience low self-esteem, isolation, stigmatization, and you also have to look at the cultural aspects of vitiligo. It's far more traumatizing from a cultural, historical perspective in some parts of the world versus others. But if I think if you take all those patients and look at them collectively, I think we certainly can make the general statement that this is a difficult disease for patients to psychologically put their arms around it. Now, we have to ask why. We've already talked about history and culture, but there's also the component of you go in to see a physician, and this no doubt is a historical perspective in the United States, and you get a quick evaluation and you're told by the physician, you know what, Mrs. Jones, I can't treat your vitiligo. There's no treatment. You just got to live with this. It's not going to kill you, so you got to live with it. Patients are devastated even more. So I think from the perspective of being a caregiver, we know that that's inaccurate data at this point. So to help patients deal with the trauma of just having vitiligo, our job as caregivers is to instill hope and to show them that we care. And hope and care goes a long way in managing a disorder condition.
It goes a long way. Couldn't have said that better. And that's what I want the listeners to walk away with, knowing that that simple acknowledgement and understanding that, hey, I may not be the dermatologist for you for your vitiligo because I'm a psoriasis expert. But guess what? I'm going to get you to someone who can, and I'm going to get you to someone who can even guide you a little bit better. And there is hope. And there's a lot of hope on the horizon. You and I are working on studies. We're part of groups that are really looking at some great stuff. In the last few minutes, let me ask you, let's go back for 1 second, because you brought up a really good point. And I love when you talk about antioxidants for vitiligo, because I am a big proponent also of antioxidants for vitiligo. I use alpha lipoic acid with vitamin C and vitamin E. If in my patients, I tell them take once a day, and you can get a combination pill or you can get them separate. I also tell them to use polypodium leucotomus twice a day. And I also check their vitamin D level to see where they are on vitamin D. What other supplements could our listeners use from your expertise?
Well, as you just mentioned, you know that I'm a supplement advocate. Some of our colleagues don't believe in supplements, but I've done it for a very long time, and I think antioxidants have the capacity to make a difference, particularly given what we know about the role of oxidative stress and impaired abilities to deal with oxidative stress that I think has been well documented in patients who have vitiligo. So what's my approach? I certainly use alpha lipoic. I also use I use fish oils. Fish oils are a great antioxidant. Sometimes I use vitamin C. Don't use that much vitamin E anymore, but you certainly can. I think, we can mix and match. And for the patient, where you feel they're not going to take multiple supplements, you can prioritize and maybe get them on just one great multivitamin that has a little bit of all these ingredients. Two brands that I particularly like, and I have no stock, no nothing in these companies. I like Thorne, I like Metagenics, I like Designs for Health. These are all great supplement companies that I think have great products. Now, I'm going to get on my soapbox for a second. What do I mean by
Go right ahead. Go right ahead.
My soapbox is vitamin D. I'm such a proponent and advocate. I think it's relevant to vitiligo. It's also relevant to overall health and well-being. There are multiple studies which suggest that vitamin D can be deficient in vitiligo. Now, what does it do? It does multiple things. It's such a powerful regulator of the immune response. And we know that there is aberrant immunity in vitiligo, but it's also a powerful antioxidant. And it upregulates some key antioxidant pathways in the body. So I typically check vitamin D levels in most of my patients, and if the levels are inadequate, that becomes a key part of their vitamin regimen, supplementation regimen as well. So that's my supplement story.
I love the way you've approached that, and you've done an amazing vitamin D video that has gone viral that I encourage our listeners to look at on social media, which I think is really powerful. And
can I tell you, we've had over 500,000 views.
It's amazing. That's fantastic. Pearl, I think our discussion today on vitiligo could go on for hours. We could talk all day long and pick each other's brain, but I think the take-home points for our listeners that I want to summarize from your astute comments are: stabilization is key. Don't be afraid to use systemic steroids in short duration in a very elegant fashion to help your patient who is spreading. Don't let someone who has facial vitiligo walk out of your office without hope, because what you and I have always said, I've heard us both say this on podiums around the world, that the vitiligo patient who still has active facial disease, those patients are being disserved, because that's the one part of the body we can do a really good job of getting better. Check labs and check vitamin D, thyroid, iron, consider supplements, use your topicals, but don't be afraid of topical steroids on the face, because you are the expert as the dermatologist, and give our patients hope. And I hope that our discussion today leads us down the road to even more podcasts that we can share with our audience in the world of vitiligo and beyond. So Pearl, thank you for being here. It's been a true privilege to share this time with you.
And it's been fun. And as you know, it's certainly a pleasure. I'm always on board to share and disseminate knowledge. And I'm going to also say some wisdom at this point.
Well deserved, and you can say that, and you can hang your hat on that. And thank you to all of our listeners for joining us today for Dermatology Weekly's podcast on vitiligo. We hope this has been helpful and informative, and we look forward to joining you again on another topic soon. Thank you, stay healthy, and stay well.